So there's a kind of twofold purpose today. One, to report back on what happened, but the second also to try and create interest in advocacy at regional and national level. So just some housekeeping rules. The session is being recorded. We will have a series of presentations by watchers, and we'll try to stick to 5 minutes each, but that might go a little bit over time. And then at the end, we hope to have some Q&A discussions. So let's see how it goes. There is translation available. So if you click on the globe icon, you can select your channel. We've got translation available in English, in Spanish, and in French. So please check which one you'd like to make use of and click on the appropriate channel. So I think in terms of housekeeping, that is more or less it. Just in terms of the watch, I want to very briefly say that the Global Health Governance Program runs the watch at least twice a year, sometimes only once a year, like this year. In January, we followed the executive board meeting of the World Health Organization. And that is a meeting where a smaller subcommittee of member states decide on and prepare the agenda for the big meeting, which is known as the World Health Assembly, that happens in May. The watch program, of course, is managed by PHM, but one of the organizations that makes it possible is Medicus Mundi International. And so it's nice to see Thomas here today because he's vital to getting us to Geneva and getting us access to the venue. And then also TWN played a big part in the watch this year. During the World Health Assembly itself, the watchers were lucky enough to have access to the building. So many of us had access to the building, and we followed the proceedings of the two committees, Committee A and Committee B. The one committee usually handles kind of procedural debates, Committee B, but often they also get loaded with substantive work when Committee A becomes too full. So what you will hear today are report backs on topics covered in both committees. And then finally, just to say that there are a series of regional WHO meetings that follow on the World Health Assembly. So these will take place from about August to October this year. And then proceedings at those meetings will also feed back again into the January meeting of the Executive Board. So I'm going to leave it at that. And without further ado, I'm going to hand over to the first two watchers that are doing a report back today. They are Mariana and Rania, and they'll be speaking on the topic of gender and how that was covered at the 77th World Health Assembly. So thank you, ladies.
Okay, thank you very much, Laurie. I will share my screen and I'll quickly talk about this. Let me check. Can you see my slides here?
Yes, we can see your slide. Maybe if you just magnify it to make it full size.
Okay, just give me a moment. Okay, so can you see it like the...
Yes, it's perfect.
Okay, that's good. Just give me 1 second. Okay. So thank you, Laura, for the nice introduction. Thank you also, Annelien, for organizing the webinar. I am Mariana, for those who doesn't know. I am a global health researcher. I'm Brazilian and based here in Berlin, in Germany. And I will be talking a bit more about gender together with my colleague Rania. I think the biggest highlight of the World Health Assembly 77 that happened in May regarding gender is this notable challenge that we're facing on the lack of consensus on the terms related to gender and women's rights and girls' health and rights. I think this debate towards the term gender highlights deep divisions that still persist, that we still have regarding the language that we're using when we're addressing the topics towards gender, which are critical. We still are far from reach like basic targets like maternal mortality, but we still on debating on what kind of terms we can actually use when you're talking about gender. And it was very clear during the World Health Assembly. So important terminologies like unsafe abortion, gender equality and empowerment of women and girls, sexual and reproductive health and reproductive rights. So these terms, which are like well established, we saw that they still remain contentious. And the disagreement surround these terms, they reflect for me like this broader necessity of a debate on how we actually balance cultural sensitivities with our commitment to put forward the agenda toward gender issues, women health, and girls' health as well. Several resolutions were affected. I mentioned two here in the slide, like the social participation resolution, also the resolution towards maternal mortality, which is key. But I could mention several of these resolutions who were like often bracketed when they have terms connected to gender, such as gender responsiveness, for instance. And one thing that it's important to mention for us who are activists is that some of these brackets were not actually clear why they were there. So it's important to us to ask and demand from WHO and member states that they actually make clear the reasons why these terms are under bracket, because this would allow us to understand and to put some dialogue and to put some efforts to create ways to overcome these differences. If you don't know why they actually cannot be used, it's hard for us to actually make actions to create a consensus. So this is something that I think we are activists, we could work on it. I feel that for the executive board meetings, this polarization is possible that we will keep going, this polemic towards gender and also towards cultural conflicts. And for us as activists, what I would say is that important to firmly root our actions in scientific evidence, also in objective analysis. Our analysis has to be objective because we need to avoid also the political use of all of this issue that would just jeopardize the agenda of women's and girls' health and rights. So I think we need to keep an eye on the actions of the member states if they're really being being objective on their assumptions and on their ideas, and also in the actions of the WHO. So I will pass the word now to my colleague Rania, and she will finalize. But before, I will just give an example of the resolution of social participation, one example of how it was adapted because of the term gender. And I feel also this is something that we can do. We can go through the resolutions and what was actually excluded, what was actually changed, to see how actually the resolution was affected by these conversations, by these conflicts of ideas and different approaches to gender. So Rania, now it's with you. Thank you very much.
Thanks, Mari. Can you hear me? I think so, right? I'll continue.
Yes, you're clear.
Thanks, Lauren. Thanks, everyone. Very nice to see everyone again. So I would just like to briefly address the context of the rejection of gender in SRHR language and how this has broader roots and implications. Mari did a great job in outlining how it appeared and in what context and the resolutions. So my job here is to just briefly give some context. And so this controversy on gender and SRHR language actually dates back to the UN Declaration in 1948, which addressed the role of the family, marriage, and gender equality when it was being written. However, disputes within multilateral organizations intensified in the 1990s, fueled by feminist groups, both from the Global South and the Global North, who pushed for SRHR language and faced backlash from religious institutions, and at the time, notably, the Holy See. And fast forward in 2004, the Special Rapporteur on the Right to Health advanced the connection between sexuality, health, and rights through its report, emphasizing that denying sexual rights makes LGBTQ plus individuals vulnerable to poor health outcomes and abuses. But He also emphasized that sexual rights benefit everyone by fostering healthy relationships and pleasure, and that they are integral to human rights. So these attempts to weaken sexual rights and gender issues need to be challenged. As Mari pointed out, we must move beyond cultural sensitivity and cultural sovereignty, which are some of the arguments that are used, to advocate for universal sexual rights that reflect these diverse cultural perspectives, rather than allowing that these discussions be diluted, which only serves the conservative religious agendas. So these efforts to undermine rights are supported by neoconservative movements globally. And just one example, these pictures that you guys see, one is in 2017 in Chile, and the other is into 2024 in Geneva, the same bus, the same organization, Citizen Go. So the same organization that was campaigning against the pandemic treaty that was in Geneva, they not only had this bus, but they also performed a big demonstration on Sunday, if I'm not mistaken, after the last day of the World Assembly. And this organization has been identified by feminist groups way before as opposing sexual and reproductive rights, particularly in regards to sexual orientation and gender identity rights in Latin America and in Africa. And they are backed by US conservative Catholic and Protestant lobby groups. And studies show that while their rhetoric is focused around SRHR, their political objectives are wider. They very ingeniously use this narrative to dismantle established human rights and public health services from within the state and favor private interests. So, yeah, I just wanted to make this comment and share this context with you. I hope that it was useful. And thanks again for the opportunity.
Thank you to Mariana and Rania. So both of those watches are from Brazil. And as both of them have illustrated, the issue of gender and beyond that, also sexual orientation and reproductive rights for marginalized communities was a flashpoint at this assembly, but also last year, when there were heavy debates about language relating to communicable diseases and access to healthcare services for example, men having sex with men. So it's a new issue, but also an old issue. Thanks, Rania and Mariana. Next, we'll have Aletta, who is going to speak to us about UHC. Aletta, the floor is yours.
Thank you very much. So as Lauren introduced, I'm Aletta Wallace. I'm a member of PHM based in Belgium. Today I will speak to you on universal health coverage. Could you please go to the next slide? So the report presented at the 77 World Health Assembly was the report that was noted by the Executive Board on universal health coverage. They also adopted a decision to develop a global strategy for integrated emergency, critical, and operative care to support the implementation of resolution WHA76.2 for the period of 2026 to 2035. The board also considered a draft resolution on social participation and health and well-being. The next slide, please. So the current state of universal health coverage today, from previous discussion and including the political declaration of the UN General Assembly, as well as this report shows the same problem. So today the world is off track in making progress towards achieving universal health coverage by 2030. More than half of the world population is still not covered by essential health services. And the majority of these are facing financial hardship due to out-of-pocket health spending. This is mostly the case for lower middle income countries, especially African countries where you cannot pay for the services you need, you cannot access the care sometimes you need. So progress towards UHC has stalled alarmingly, and also the financial protection has worsened for more than 2 decades. the failure to implement this is also based on the failed strategy and approach. So there is also a lack of inadequate funding. Just some highlights from the discussion at the 77 World Health Assembly. So member states have emphasized the importance of social participation in achieving universal health coverage, and some member states also mentioning its importance in addressing NCDs. This was supported by several member states. Social participation regulation included the following acknowledgement of what kind of social participation WHO encourage, noting the need to prevent, manage, and mitigate conflict of interest to uphold the integrity of the social participation through enabling legitimate representation to ensure that the private and personal interests do not override public health goals. So in the EB version, the resolution also referred to the needs for policy to be gender responsive, but this was also is not included in the current resolution. Country calls for increased access, coverage, and financial protection to achieve universal health coverage. They also acknowledge the importance for the primary health care plays in achieving this, and they call to make services available for marginalized populations. While some countries were noting the significant progress they have made, African countries also highlighted the urgent need to close the gap and also increase access to quality and affordability, especially in low resource and fragile health systems. So what's needed? The need to strengthen public funded and public administered health services. There is also a need to strengthen the health system and healthcare workforce to achieve universal health coverage and expand primary healthcare services and orientation of health system towards a primary healthcare approach. The need for countries to invest in health at country levels and reorient health systems and investment through primary healthcare approach with strong political commitment. There's also to increase access to essential technologies to ensure that the universal health coverage is achieved. And also we need to continue to measure and report on progress, but also reduce vertical programs. So thank you.
Thanks, Aletta. And maybe just to highlight something Aletta pointed out in the presentation, the social participation resolution that was passed in support of promoting UHC had this paragraph that made a distinction between social participation that tries to advance private interest versus social participation that tries to advance the public interest, and that's quite significant. So otherwise, quite a bleak picture on UHC, as again, as last year and again this year, WHO confirming that it's not on track to meet UHC targets. So that continues to be an issue for the World Health Organization. So next we have Ben, who's going to be presenting on the topic of Palestine, which was extensively discussed at the South Assembly. Ben, please go ahead.
Thanks, Lauren. So the night before the 77th World Health Assembly, you might remember the Israeli army attacked a displaced persons camp in Tal El Sultan in Rafah, an area that had previously been declared a humanitarian safe zone. 2 US-made bombs were dropped from Israeli warplanes on the camp, killing at least 50 Palestinians, many of whom burned alive in their makeshift shelters that they had been forced to be displaced to. And at least 200 people sustained injuries. This is just one event that's emblematic of the whole conflict that's been going on for the past 9 months, and this really set the tone for us going into discussions around Palestine at this year's assembly. Contentious discussions about the health of people in the Palestinian territories has kind of become an annual tradition at the World Health Assembly. The agenda of every assembly since the late 1960s, actually since after the Six-Day War in '68 and the Nakba, has featured an item focused on, in one way or another, on the health conditions of people in the Palestinian territories. Discussion every year is based on a technical report that's produced by the WHO Secretariat at the request of the Assembly. This item is always accompanied virtually always accompanied by a draft decision, typically containing language denouncing the health effects of the Israeli occupation of the Palestinian territories, which is now in its 58th year, and requesting the DG to once again report on the health conditions in the territories at the following assembly. So you can see how there's this cyclical effect where we have these reports every year, and the item tends to conclude with a decision calling for the DG to come back next year and do the same thing. Invariably, most of the discussion around this item consists mostly of mutual mudslinging and rhetoric between supporters of Palestine on the one hand and a pro-Israel contingent on the other hand, led by the United States. And invariably, this draft decision is brought to a roll call vote in the Assembly, which, as most of you will know, is relatively unusual. Almost all decisions and actions from in the World Health Assembly are kind of routinely adopted by consensus. This year's Assembly was unusual in that member states were invited to consider two technical reports on Palestine: the standard annual report on the health in the occupied territories, which in this case was abbreviated to focus on the period prior to October 7th, and a second report on what's really an unprecedented health catastrophe in Gaza and the West Bank that's obtained since the start of the war, that was discussed alongside other items under other acute health emergencies under item 14.1. So I'll try to discuss these, focus mostly on the first report, but I'll give you some very briefly some of the details about both. First, I should say first, accompanying these two reports were two draft measures for the Assembly to consider adopting. The first, under item 20, is a 4-page draft decision, essentially a beefed up version of the standard draft decision that's introduced every year, asking the DG to report on the health conditions in the territories. And the second is a resolution which emerged from a special session of the WHO Executive Board that you might remember took place in December of last year, focusing on humanitarian relief, the free flow of medical aid, and the rebuilding of Gaza's health system. At the time, this was the only such resolution that had come out of any UN body and that was approved by consensus. And I'll come back to both of these. First, the draft decision under item 20, which was submitted by 32 countries, most from the Eastern Mediterranean region, but accompanied by Russia, China, South Africa, and others. This year, as you might expect, this standard decision had much stronger language than usual, referring, for example, to the wanton destruction of the Palestinian health system and forced displacement of civilians by Israel. It called for Israel to fulfill its obligations under international law to guarantee the safe passage of medical supplies, personnel, and equipment, and so forth. And it also mandated WHO to hold a donor conference to support the health needs of Palestinians, and to finance the rebuilding of the health system after the war. As expected, this draft was met with a great deal of resistance from Israel and its close ally, the US. So as sort of a strategy to stifle the decision, Israel proposed an amendment calling for the release of hostages that were held in Gaza without any mention of the thousands of unlawfully detained Palestinians who are currently being held in Israel, and also including a condemnation of the use of health facilities by armed groups in Gaza. And what followed was a counter amendment condemning attacks on medical facilities by Israel and referencing the ICJ court orders against Israel. This counter amendment was proposed by many of the sponsors of the initial draft decision. So there was this sort of tit for tat of amendments on the floor of the Assembly over the course of a couple days. All of these amendments and the consequent decision ultimately passed through a series of roll call votes that dragged out for several hours on, I think, the second to last day of the Assembly. But it did not pass without a large number of abstentions, and certainly not without some heated discussion. So I'll just summarize that very quickly. Many countries on the floor voiced their profound distress about the catastrophic health situation in Gaza and the West Bank. Several acknowledged that Israel is committing war crimes, Many advocated for a ceasefire, and some described the situation as genocidal, consistent with findings by Francesca Albanese, the UN Special Rapporteur. Notably, in the substantive debate, only 3 countries from the global north intervened, Norway, Ireland, and Spain, with the rest remaining conspicuously silent. Some others intervened to discuss very briefly the reason for their votes of often no or their abstentions from the decision. Very quickly, the second measure that was being considered, the draft resolution that came out of the EB special session. This resolution demanded increased aid access to Gazans, called on all parties to adhere to international law, and mandated WHO to plan for the rebuilding of Gaza's health system. This got a little bit of press coverage when it was initially passed by the EB, partly because of it being passed with consensus, but also its mention of a humanitarian ceasefire. But it's important to note that it doesn't actually call for a humanitarian ceasefire. It just sort of mentions it in the preamble. So just something to take note of in the details. This resolution, even though it was approved by consensus at the EB, was actually brought to a vote at this assembly, which was considered a kind of a low moment, because never before in WHO's history has a resolution passed with unanimous support at the executive board, only to have to be brought to a roll call vote at the WHA itself. And notably, the US, which supported the initial resolution at the EB, abstained from this version of it. So I just want to talk about, in the last minute or two here, beyond the substantive debates around these measures, one big theme that emerged was this idea of politicization. So several member states expressed regret, as they do every year around this topic, and I think it was even more pronounced this year, expressed regret about the WHA tipping too much into politics. So there's some quotes on the slide to illustrate this. And really, I won't read through them, but really the only thing that the countries seemed to agree on in this whole assembly was that politics is bad. This came from both sides of this debate. And tipping into political issues somehow cheapens the WHA forum. And this was one of the main themes that came out of media reporting on the assembly as well. So I kind of want to just raise a question and something to ponder as we move on, is whether all that I've just explained really amounts to undue politicization. It's definitely political stuff, but why is it really a problem? So today in Palestine, we have people dying from starvation, from malnutrition, untreated wounds, diarrhea, infectious diseases, untreated cancers, diabetes, heart disease, and so on. These are causes of death that are technical and biomedical and should be addressed by a body like WHO. But what about their upstream determinants? I think these are undebatably political factors. Oh, my screen's frozen. There we are. These factors like settler colonialism, the deprivation of Palestinians to the right of self-determination, the 58-year-old military occupation, the system of apartheid that prevails in the West Bank, and violations of international law. These are political issues, but they're also really the core determinants of health that affect Palestinians today. And if we're going to advocate for an evidence-based approach to public health, and one that identifies social determinants of health, and then subsequently kind of organizes ourselves to address them, we have to focus on all modifiable determinants of health, not just the ones that we think are sufficiently apolitical or non-controversial. So that's kind of just the message I wanted to wrap up on. Thank you very much.
Thanks, Ben. I think definitely the past 2 years we've seen the entry of geopolitics into the debates much more than in the past, and it's played out in debates about Palestine, debates about Ukraine, debates about gender and women's rights. And so I suspect that is going to continue. Recently also there's been an announcement that NATO is likely to open a public liaison office in Geneva, and this has put on the map the question of the neutrality historically of Switzerland. So I think we'll continue to see debates about geopolitics play out in WHO and probably other UN institutions based in Switzerland. Next, we have Juliette, who is going to speak about climate change and how that was addressed at WHA77. Okay, go ahead, Juliette, please. You're muted.
Sorry, I'm in a train, and right at the moment I want to speak, the lady of the train also spoke.
No problem.
But I hope you hear me well. I'm happy to be here today to discuss the climate resolution that has been adopted last WHA. And maybe before we start, it's interesting to note that the last climate resolution that had been adopted was from 2008, and that this resolution has been proposed after a lot of advocacy efforts from civil society and been proposed by youth delegates. And I don't know how meaningful it is in the end, but the efforts and the agreements that have been made are in part due to civil society's efforts. So next slide, just a brief intro, but I think most of you know it, how the planetary crisis deeply affects our health. So the WHO already stated that 23% of the world's mortality is related to environmental impacts, and climate crisis affects each aspect of our health. So we have direct mortality and morbidity. Oh, just a minute. So we have direct mortality and morbidity due to extreme weather events, heat stress, aggravated cardiovascular and pulmonary diseases, and also threats to food and water safety. But we also see rises in infectious diseases, mental health crisis, and civil unrest. And on the other graph, which you see on the right, you see how disproportionately some actors have been more responsible than others for this planetary crisis. So the global north counts for 92% of the excess emissions. Then the next slide about recent agreements, the most important one being Paris, which is binding. And it has not only been binding in an agreement to decrease our net emissions, but also has endorsed the right to health. But what we see when Paris translated to national policies is that only 10% of the nationally determined contributions actually endorse health and the right to health, and there are no integrated climate and health policies, which was also one of the reasons to come up with this resolution. And very short on the right again, you see the graph from the IPCC report, and the blue line is the one we should follow in terms of. Oh, again, sorry. I just came at the wrong spot, I guess, for the train. But the steep blue graph is the one we should follow in terms of carbon cuts. And that is very, very ambitious, but it's the only one that can protect our ecosystems and our healthcare. So about the climate resolution on the next slide. So what does it say? In the preamble, it does recognize climate change as a major threat to public health, and it also underlines that the scientific community agrees that there is an urgent need for action. What it also recognizes is that health systems also contribute to environmental pollution. On average, that is 5.3% of the global carbon emission. It doesn't note that the high-income countries have a much higher percentage of their healthcare systems contributing to these global emissions. It also recognizes the inequalities that are aggravated by the climate crisis, but doesn't explicit except for gender, which marginalized communities are more vulnerable than others. And what also has been challenging during these debates is the common but differentiated responsibilities, which means that the countries that are more responsible for the climate crisis also should take more action. It's very shortly noted in the preamble, but it is not mentioned in the call to action. So it's a very weak claim that we see there. And what is mentioned in the call to action in the end is mainly about the implementation of the WHO existing strategy on climate change and health, and assessment of vulnerability, data monitoring of the health impacts of climate change, but also the implementation of climate and health policies on a national level. For example, in the nationally determined contributions. There's no mention of mitigation measures directly, but there's a call to collaborate with WHA77 to create more sustainable health systems, a call to action for multi-sectoral collaboration, and also to fund further research for climate and health. And then lastly, to reflect a bit on what is left out of this treaty, or this resolution. So what we see is that the planetary crisis is reduced to the climate crisis in this treaty particularly, and that makes that there's no integrated approach to the different but correlated ecological crisis going on. I already mentioned the common but differentiated responsibilities part, and we also see that financial support is missing from the call to action. And what's very, very clearly missing is that there's no mention of fossil fuel effects, no mention of their direct health harms or their contribution to the climate crisis, and the role of the private industry is completely missing. And the gender phrasing barely survived the resolution, but any other marginalized groups was not explicit into it, while they all have different health needs within the ecological breakdown. And also in the process towards accepting this resolution, we saw very little community engagement or even civil society engagement, and that value is also completely missing from the text. And then last slide, where are we moving towards? So this process is not finished yet. On the coming year, the member states that endorse this resolution will be working also on the global plan of action that will be discussed next WHA, but also during the UNFCCC frameworks. And we will see more WHO presence at UN meetings. And as the DG got the mandate to be a leader as well in climate and health, we may see him, for example, at next UNFCCC discussions, and progress reports are to be expected. So all in all, I think that what this resolution calls for is adaptation measures to tackle the health effects of the climate crisis and sustainability of healthcare systems, but it is not addressing the core roots of where this climate crisis comes from, nor the inequality that persists.
Thanks, Juliet. I think, as you point out, the resolution is non-binding, but clearly WHO is concerned about the impact of the climate crisis on its work. This year, much of the documentation focused on what it referred to as the poly crisis, so there is an acknowledgement of that. And then there's also, every year, it seems more and more of WHO's work that gets done in the context of health emergencies, and many of those emergencies have been caused by climate-related disasters. So it's clearly an organizational concern, but as you point out, the way forward is not very clear beyond perhaps at this stage, just suggestions about how to move forward. So next we have Annelien, who will be presenting on behalf of Raquel. Raquel Rashid was also a watcher from Brazil, and she couldn't be with us today, unfortunately, due to another commitment. But she prepared a presentation on the fundraising efforts that WHO has launched. It's got a new model for fundraising for itself that it refers to as the investment round. And so Annelien will give us some more detail about this investment round that was launched officially for the first time this year.
Thank you, Lauren, and hello, everybody. Yeah, to just emphasize that the work on this presentation is really done by Raquel, who unfortunately couldn't be here. So I don't want to shine and borrow light. It is her work and her analysis that will be presented. So yeah, she starts with just first mentioning how this report, which is called Sustainable Financing, the WHO Investment Round report, how it was discussed under the agenda item 18, but also how it was related to other items on the agenda, such as the discussion on the 14th General Program of Work 2025-2028 and its financing. So this report actually speaks to the budget that is attached also to the program of work. In terms of process and objective, considering the EB's decision on approving this plan for an investment round in January, there was a report presented at the Assembly and its progress, and thereby actually launching the investment case, which informs this popular narrative about health as an investment rather than an expense, which is a very different way of looking at it. And therefore also emphasizing this kind of idea of investing in the WHO will lead to economic return. So that is a motivation for attracting funding. The objective of this first round, arranged by the organization, was this to rally stakeholders for what one calls a donor-based expansion that specifically welcomes, and there you have it, private sector donors through the WHO Foundation. And of course, that is in a move that we know also consists of increasing this opaqueness about the funding of the WHO and its financing. It's quite worrisome. We took 2 slides from the member states information session that was held by the WHO in April 2024. On the top left, you can see a little thermometer which indicates the total budget needed for the general program of work. Its base budget is about $11.1 billion. One can see that actually the projected assessed contributions in PSC comes to about 4.1, which leaves a funding gap of about $7.1 billion to implement this general program of work. And then the second slide of their information session to member states presents this kind of new resource mobilization and advocacy strategy, which include member state contributions, also philanthropy, but includes also how the WHO Foundation outreach actually has begun including the private sector. And because it's through the foundation, it becomes a bit tricky to know what is funded by what. So moving on, Raquel pointed out that if we look at the roadmap ahead and the timeline, the main event that is coming up will take place in November during the G20 event that is hosted by Brazil. And she mentioned how, as a matter of interest, how during the G20 presidency of Brazil, Brazil actually has been showing positions that please the international markets. And one can see that how it exposed its public universal health system, which we all kind of look at, to really a privatizing perspective. So she mentions how this is particularly manifested by the digital health model adopted by Brazil, which when one looks and analyzes this, it's a direct result of international influence from institutions such as the WHO, but also OECD, and then Denmark and the UK specifically. Finally, the general program of work was approved, and the Assembly was invited to note a report on the investment round and its roadmap calendar. So Raquel concludes that all of this shows how needed are the discussions about international organizations shaping health governance processes of states, including its financing in the current capitalist phase of accumulation. So that is really something for civil society to take on, because these discussions will not happen within the WHO events or in the corridors or in that sphere of decision making. So this kind of how these organizations shape democratic processes and governance processes within states is quite worrisome. And she adds to that something to watch, and that is also how these processes shapes struggles over how digital transformation has to be faced. So I think this is what Raquel wanted to convey to you with regard to the investment round. So thank you very much. Over to you, Lauren.
Thanks, Annelien, and thanks again to Raquel for putting together the presentation. So we're going to move from a funding crisis to another kind of crisis, a crisis of infectious pathogens. The next 2 presentations will look at some of the legal reforms at the global level, that have been tabled in response to the COVID-19 pandemic. So first we'll hear from Navamohana, and he will speak to us about reforms to the international health regulations that were tabled at the 77th Assembly. Navamohana.
Yes, thank you. Can screen sharing be enabled for this? For me?
So it doesn't look like screen sharing is enabled, but I'll try and make you co-host.
Yes.
And then you should be able to do it. Sorry about that.
It is done, so you should be able to.
Okay.
Yes, are you guys able to see my screen? That is the slideshow of the presentation.
Yes.
Okay, thank you. So, hello, I'm Navamohana Krishnan, also a part of the WHO Watch team. So I'll be covering what happened with regard to amendments to the IHR, that is the activities of the working group, how it was tabled before the Assembly, and what was the outcome. So, I wouldn't be going much into detail about what the IHR actually is or what it discusses. I'll try to cover what amendments that they tried to do and what was the need for the amendments and did they achieve what they sought to achieve in the end. So the working group on international health regulations was established through the World Health Assembly in 2022, that is the 75th session. It was in line with the 150.3 EB decision, which wanted like potential amendments could be made to the international health regulations to ensure equitable measures, so that equitable measures can be taken in order to protect the international spread of diseases. So in line with it, the WHA77 held 8 meetings and other sub-meetings like follow-on meetings between 14th November 2022 and 24th May 2024. That is up until the 77th World Health Assembly. And the document A77/9 was tabled before the Assembly for discussion. So the Bureau basically presented the draft of the proposed text, which had highlights in green and yellow, which were like good to go with or like need much more discussion. But it was more closer to being agreed, like achieving consensus, but required a little bit more discussion during the assembly. So agenda 13.3 was the discussion about the working group or the outcomes of what was achieved through the working group. It was discussed in Committee A on the second day of the assembly. However, the discussion during that particular session of Committee A was not enough to reach consensus. So WGIHR drafting group was established to function in parallel with other committees of the assembly. The negotiations that happened inside this drafting group happened behind closed doors. So there was no regular update of what was the arguments or timely updates on what the negotiations were about. Compared to the pandemic instrument negotiations, the negotiations with that happened in WGIHR was considered to be more streamlined and predictable. So the thought was that a consensus could be achieved much more sooner, and hence there was a heavy push for coming to an agreement by the end of the 77th World Health Assembly session. So yes, the negotiations largely focused on Article 13, which was about equitable access to relevant health products, a little on that a little later. Article 44 on collaboration, assistance, and financing mechanisms. And then on Article 54, that is 54 bis, which discussed about or which establishes a new committee for the effective implementation of IHR. So earlier it was just updates given in the during or in between the World Health Assembly sessions. Now a separate committee can discuss and take decisions on it. So that was something which was negotiated for. So the developing countries, including the likes of Bangladesh, Ethiopia, Kenya, and all, like criticized like the short negotiating timeline which was advocated for. They wanted to like ensure proper support to the developing countries through equity, the principles of equity and solidarity, and they wanted to push for the need for technological transfer, know-how, and a separate financing mechanism, a separate fund just for within the IHR agreement, which can be used to during emergencies, health emergencies. On the other hand, the developed countries, such as US, UK, Canada, were more focused on promoting early warning systems and surveillance mechanisms. They heavily pushed for arriving at consensus before the end of the 77th World Health Assembly session, and they were completely against a separate additional financial mechanism just for the IHR. So what happened was on the last day of the assembly, that is on June 1st, France, Indonesia, Kenya, New Zealand, Saudi Arabia, and the United States proposed a draft resolution before the assembly, which was adopted by consensus. The document is World Health Assembly 77.17. It's a resolution. That document should now be available in the chat box, where the changes made to the or the amendments made to the IHR would be highlighted in bold, and the removed ones would be given in strike through. So yes, let us look at some of the major amendments in brief. So what happened was equity and solidarity were included as guiding principle when it comes to like interpreting other significant provisions of the IHR. There was a push for, in between, during the working group was functioning, there was a push for common but differentiated responsibilities as a guiding principle, but however, that was left out during the working group process itself. Then Article 13 was the base, like basically much of it considering equity. It now provides for international assistance to facilitate equitable access to health products such as diagnostics, vaccines, and therapeutics for responding to public health emergencies of international concerns, that is a peak, as well as a pandemic emergencies. So basically, the IHR, after being amended, now also contains a separate definition of what constitutes a pandemic emergency. This will be assessed and determined based on the conditions prescribed by the Director General on a timely basis. So that has also been included. So 3 new paragraphs have been added to Article 13, which constitute most of the equity-based amendments or equity-related amendments to the IHR. That is, paragraph 7 mandates WHO to support IHR state parties during health emergencies. Paragraph 8 suggests the role of WHO in facilitating timely access to relevant health products. So now, after the amendments, apart from medicines, vaccines, diagnostics, and therapeutics, health technologies now also form a part of relevant health products. So therefore, when it comes to transfer of technologies, it becomes much more easier now for countries, because technologies now form a part of relevant health products, and now that coming into equity makes it more a bit more easier, and or like the document encourages for it. And then the new paragraph 9 under Article 13 obligates state parties to support the WHO in implementing the rest of the provisions of Article 13. However, there is a small catch which says that this obligation is subject to applicable law and available resources at the national level. So that is something which might be a little problematic when it comes to mandatory obligation of support to the WHO in implementation of Article 13. But that once again comes into implementation and how countries work together. And then Article 44 was another major amendment. I mean, it faced another amendment to increase international collaboration and assistance, including for mobilization of additional financial resources. Article 44 bis was incorporated to bring in a coordinating financial mechanism, which uses a threefold approach, focusing on timely, predictable, efficient, and sustainable financing for implementation of these regulations. As discussed earlier, like since the implementation of IHR could only be discussed between the meetings of the World Health Assembly, Article 54 bis established the State Parties Committee for implementation of IHR, where they could discuss in detail the challenges, strengths, and weaknesses associated with the implementation of IHR. Then Article 4 was amended to establish a new national IHR authority as well as IHR focal point, which would create a network of regulatory authorities just between the WHO so that information could be shared on a regularly and a timely basis between the IHR authorities and the WHO. And then in Article 6, information sharing about the spread of a new disease need not be just only to the International Atomic Energy Agency whenever they were relevant, but also to other appropriate and competent intergovernmental organization when it concerns them. When the spread of disease, that organization needs to know about. So that is also now possible. And yes, lastly, way forward. So yes, this adoption of amendments to the IHR is definitely historic, but what lies ahead is better and bona fide implementation of these amendments. Not to forget that the states do have the right to reject or reserve certain amendments. But when they reserve certain amendments, they need to provide valid reasons in writing under Article 62 of the IHR, but no such requirement is needed for rejecting the amendment as a whole under Article 61. So the current situation is that most IHR state parties now have 10 months to either reject or reserve from the date of notification by the Director General of these amendments and proposed amendments. And then this will come into force 12 months from the date of notification. So with regard to what lies ahead with the 156th Executive Board meeting, there is not much because it is now up to the state parties to implement these into their national laws and take mechanisms to report on this. Probably we can expect a mention or two like in the previous year about this entire IHR amendment process turning out in the reports regarding health emergency prevention, preparedness, and response. So it is up to the states now to take up this and work in good faith. So that's it. Thank you.
Thank you, Navamohana, for a very comprehensive overview. So in a way, the IHR is a good news story when it comes to PPR at the Assembly because some kind of constructive conclusion was reached. The story of the INP is very different and a much more frustrating one. So I'll hand over to Alessandra now to speak to us about what happened around the negotiations for the pandemic accord. Alessandra?
Thank you so much. Do you see my screen now?
Yes.
Okay, perfect. And I guess you can also hear me.
Yes, we hear you.
Okay, so I can start. Okay, perfect. So thank you very much. So my name is Alessandra, and I will try to guide you through this pandemic treaty negotiations. So, oh, wait a minute. I can't do anything. Why?
If it's stuck, maybe try and exit share screen and start again.
Yes, I will. If I do it like now, like this, is it bad? Because it's not actually presentation mode, but I cannot. Let me see, huh?
Yeah, perfect.
Okay. Okay, perfect. So thank you. I'm sorry. So just a little bit of background. The International Intergovernmental Negotiating Body was created in December 2021 with a special session of the World Health Assembly with the aim to draft the pandemic treaty by May 2024. So by this WHA77 World Health Assembly. And its main goal, I mean, among its the various goals, like the most important goal that it had for me was the fact that it had to ensure equitable access to pandemic countermeasures, especially to least developed and developing countries. And the negotiations of the pandemic treaty lasted 2.5 years. You can see here on the screen we had 9 sessions of negotiations, and each of these sessions produced a draft pandemic treaty text that unfortunately did not reach the consensus needed. And especially the last negotiating session were very long and very tiring. They went on extra time, really days and nights. And this is not it's not a coincidence that the last draft text of the pandemic treaty was actually published on the 27th of May, which was actually the first day of the World Health Assembly, because negotiations of this pandemic treaty really went on also on Friday and on the weekend before to try to reach a consensus that unluckily was not could not be reached. And for this reason, the World Health Assembly decided at the end to prolong these negotiations until December 2024, so with special session of the World Health Assembly, or if more time would have been needed, until May 2025. And the picture that you can see here shared on the screen is a little picture that I have taken from the pandemic treaty draft that has been shared by the INB with the World Health Assembly. As you can see, it's kind of a rainbow picture with a lot of color coding. The green highlighted text is the text upon which there was agreement and consensus. The yellow highlighted text is the text upon which there was not consensus, but there was a sort of convergence. And the white text is the text on which there was no consensus. And if you can look closely, you will see a lot of brackets. And the bracketed text is the text that is problematic for some countries, text that some countries want to add, text that some countries want to delete. So it's actually it's a text that it's very hard to really also to read, because with all of these colors and brackets, and you really have to think that it's not that you have one full article that has been green or yellow, but you have part of an articles that are green, part that are yellow, part that are like non-highlighted. So there is a lot of confusion. And among this confusion, it's really not it's not a surprise that the most controversial topics are the One Health instrument, so Article 5, the PAPS, so the Pathogen Access and Benefit Sharing instrument, Article 12, technology and know-how sharing, so Article 10 and 11, and then on a more like systematic way, I would say like the financing of the treaty, the legal architecture of the treaty, especially its relationship with its possible protocols, which will be the protocols of the 2 instruments, and also the relationship between INB and IHR, and among, in general, also a weak legal language. So flash forward to almost 1 week ago, on the 16th and on the 17th July 2024, member states delegations reunited again in Geneva for the first meeting of the new set of negotiations that will be going on up to December. INB 10 was not, I would say, like a content-related oriented INB, because its main goal was mainly to discuss the methods of the negotiations, time and agenda. The first thing that was done at INB 10 was the rotation of the bureau, something that was asked by the World Health Assembly. And so here we had the French ambassador, Anne-Claire Amprou, that substituted Roland Dries as INB co-chair at interim. And actually, as you can see in the screen, INB then set the timeline for the next negotiations. So we have negotiations in September, in November, and then if more time is needed, also in December, February, and April 2025. And highlighted, there is this date, which is the 11th of November, which is a very important date, because by this day, member states will have to decide if they can agree on a pandemic treaty by December, which means if they are about to call a special session of the World Health Assembly. So there is a bit of time, but there is not that much time actually ahead of us. INB 10 also shared the schedule of the INB 11 negotiations that will take place in September. And as you can see on the screen, priority has been given to the most contended issues. So again, Article 12, which is the PAPs, Articles 4 and 5, which is prevention and One Health instrument, Article 10 and 11, which are the transfer of technology and know-how. And then we have on the first morning at the opening, actually, we have the topics on the legal architecture of INB. And as you can see, every day there is at the beginning of each day a 30-minute stakeholder sessions, which mean that non-state actors can participate to the session, listen the daily agenda, and understand what has happened like the day before, what has been discussed, what decisions have been made, and give some inputs. This is actually the only, we could say, win that non-state actors have had. This is unluckily a very sad win, because at the beginning of these negotiations, non-state actors had a very, very high expectations that things would change and that they could participate and engage much more directly with the, with the negotiations themselves. Despite the endorsement from many member states, for example, like Colombia was very important, because she really highlighted how civil society organizations are extremely important for them in the negotiations, and they want them to be engaged directly in the negotiating process. But like, despite this, some member states, which are Russia, China, and Nigeria, were against the presence of stakeholders in the negotiations. So the INB co-chair opted for the, we could say, like, business as usual closed door negotiating session. A few minutes every day, just like try and make a meaningful impact, are, of course, like, really insufficient. INB, okay, sorry. So INB also set the agenda for a new kind of meeting, this so-called like hybrid formal informal meeting that will take place some days before each INB, and that will discuss about the most important topic that will be negotiated during the official INB negotiations, and will also have the possibility to have some interactive dialogues with experts that can be suggested by member states, but that will ultimately be decided by the WHO himself. So a little bit of stock taking. What is our take on this? So on the WHA77, we actually, given the mini unresolved issue, we can only welcome the decision to prolong the INB. This was also one of the asks of the PHM watchers and activists. But our position on INB 10 is completely different. As I said before, civil society organizations are still sidelined in the process. And then there are also some other concerns regarding, for example, these informal formals for INB 11 or INB 12, because they have been scheduled in moments where there are also other WHO regional meetings, especially in Africa and Asia, making it extremely difficult for small delegations to participate, because small delegations are normally like one-person delegations, and this means that they will have to split themselves between two parallel meetings. Additionally, we already know that the INB informal meetings that will take place at the beginning of September will collide with another WHO internal meeting, which means there will be no interpretation available. And many member states lamented themselves, telling that like such a process is not does not ensure transparency and not even equity. That's simply like not fair. But the answer from the INB co-chair was not really reassuring, because they only said, well, those are informal meetings, so your presence is not mandatory. Additionally, also the proposed way to go for negotiation is a bit raised a bit concern in some, because many member states expressed the wish to start the negotiating process where it was finished, so in May, so with starting from this yellow and green highlighted draft text that was presented also to the WHA. However, it's true that like there has been like consensus or convergence on the text, but like this consensus has been reached under a very, very high pressure in the days, if not hours, before the WHA77, with the hope like to produce a treaty that could be actually also approved. And also a lot of this convergence has been reached in a smaller setting, maybe informal setting, where small delegations could actually not intervene. So now the situation is different, the framework is different, so some people ask for actually more flexibility. And with these premises, I mean, the conclusion is that once again, least developed and developing countries risk being unjustly penalized. And then I think I am really out of time, so we'll just give you this sentence that was pronounced at the end of the INB 10 by Dr. Michael Ryan. And I think it's very fitting, and it's very also passing, because it really, I think it really gives us again the sense of what we're doing, especially saying this is not an academic or political exercise. This is an exercise in saving human lives. That is what delegates are doing when they're negotiating. And too often it seems that they forget about it. I think I will stop there because I think I'm already over time. And thank you so much.
Thank you, Alessandra, also for a very comprehensive overview, and for also kind of outlining what's supposed to happen in the months ahead. So we have 2 more presentations left. The next is by Indra Chapa, who's going to speak to us about antimicrobial resistance, AMR. Chapa.
Thank you, Lauren. Thank you, everyone. Let me share my screen. Hope it's visible. Yeah. Hi, I'm Indra Chapa, and I'll talk about the antimicrobial resistance, which is the agenda item 11.8. So for those who don't know about antimicrobial resistance, it's actually when the microorganisms develop resistance for the medicines that intended to kill them. And this is a global issue because these resistant microorganisms can spread through not only people, but also via food chains and environmental factors. And so that therefore the available treatments would be ineffective, and that would increase many deaths and the burden in the health systems. So I'll quickly talk about the documents that was discussed during 77th WHA. One was the DG's report on antimicrobial resistance, which is noted, and also the resolution on antimicrobial resistance was approved on 30th May during 77th WHA. So this report is actually very comprehensive and detailed, but and also the resolution is a progress, a way forward, but PHM identified some gaps, although the resolution acknowledged that the several contributing factors other than in human health sector, but also the animal health sector, agriculture, and environmental factors. But PHM comments that these 4 strategic priorities acknowledged by this resolution is actually focused on human health sector. And also the first priority, the governance and collaboration, although it includes multi-sectoral governance mechanisms, that when it comes to low and middle income countries, it lacks that the access to essential capacities and information. So there's no point of discussing about high cost diagnostics when they lack those capacities. And when it comes to strategies regarding prevention and control, in the second pillar, although it emphasized increasing immunization coverage, that it doesn't address the preventive measures, the lack of structural the structural determinants for the lack of WASH services, and also the regulations. It doesn't address the regulation on private sector and the agriculture and animal health sector, because those sectors are almost driven by the commercial pressures. And when it comes to third and fourth pillars, the research and innovation, though it promote though they encourage the promotion of local production and research, there's no mandate on public acquisition of IP rights. And also the integration of these surveillance data into, like, for strengthening the overall health systems, it's not detailed in this resolution. So that's why PHM, as PHM, we recommends some certain measures to incorporate for the political declaration before the next high-level meeting in September, that such as measures such as banning preventive use of antibiotics in agricultural and animal health sector, and also regulating private healthcare markets. I'll highlight one event from the WHA77 WHA that during the session, IPF, the International Pharmaceutical Federation and International Federation of Pharmaceutical Manufacturers, they intervened, mentioning that regulation on non-prescription antibiotics would lead to delays of treatment, and that would disadvantage the communities. But those subtle intentions are the reason that PHM reiterates the importance of incorporating these measures to regulate private healthcare markets, because in addition to all these measures, those private sectors that are driven by the profit-oriented private sectors should be regulated, because AMR is such a huge issue that would risk the lives of all the underdeveloped countries, the communities in underdeveloped countries, and all the communities, the globe in general. So, there I'll conclude my presentation. Thank you very much.
Thank you, Chapa, for an excellent presentation. And actually, your reference to the IFPMA made me remember that they also intervened in the item on universal health coverage to indicate that there are many drugs that they can share to help countries manage NCDs like diabetes. So there is a definite kind of medicalization of these kinds of interventions that private sector aligned civil society organizations are pushing. And like you say, we're pushing more for a focus on the social determinants. So thank you. So finally, we have Paul, who will be presenting on the official item on social determinants of health, and then also the Commission's report on economics of health for all.
Hi everyone. So I'm the last one, and I'm sure people are tired, so I'll make this quick. I am tasked to discuss about economics of health for all and social determinants of health. These were both lumped together in agenda item 15. Agenda item 15.1 on social determinants of health, and 15.5 on the economics and health for all. But this was also lumped together with discussions on maternal mortality, child nutrition. So these were, there were actually lengthy discussions on all these things, where for us watchers, it has been confusing at times due to the wide range of topics discussed. Some member states would actually give a comment on a certain agenda and then jumped on another one. So it got a bit confusing. But anyway, so on the social determinants of health, the main document that was discussed was EB 15421. I'm sorry, I wasn't able to put that in the presentation. But anyway, there was a progress report of the World Report on the Social Determinants of Health. Basically an update on the 2018 2008 report on the implementation of the social determinants of health. So some countries actually expressed concern about the slow progress of the implementation of the 2008 recommendations. Mainly in the WHA, we noticed countries like India and Norway expressing their alignment with the regional strategic framework for social determinants of health. From 2023 to 2030, focusing on addressing health inequity, social justice, and economic, commercial, and digital determinants of health, among other stuff. And then I think if you browse through the WHA journal, and I actually looked back into the Watcher's notes, our notes, it seems the social determinants of health were just discussed in passing. But anyway, so the economics and health for all, there was a resolution proposed or tabled by Austria, Belgium, Brazil, Canada, Norway, Netherlands, and UAE, among other countries. This document was A77A Conference 2. During the discussions on the issue, well, many countries actually raised or emphasized the necessity of investment to guarantee a health for all agenda, and stress the needed collaboration between sectors to address social determinants of health. So that is precisely why these two items were grouped together and discussed together. But I think highlighting is one of the highlights was USA criticizing the expense of the proposed portfolio. And also, Iraq noted the lack of precise information on how states would implement the guidance. That is also one of the remarks that we made, is that how the implementation of this it's truly wide, and the implementation might necessitate deeper details. Okay. But anyway, this was previously with Committee A, then transferred to Committee B, and the Committee B finally approved the resolution contained in the resolutions contained in the said document during the 6th meeting of the Committee B. So what is in this document? So it's generally the council proposing a narrative about the interlinkage between health and economy, the emphasizing the urgent need to reorient economies to deliver health and well-being for all, and it argued that the cost of inaction is higher than the cost of action. So I'm just posing here the comments of PHM. Next slide, please. Of course, we understand that there should be no debate about health versus economy. The two should actually go together. So it is an excellent idea, and if achieved, it would actually make a difference. But the agents who will drive the change were not identified in the document, and they're wise in-house. There is also no analysis on the barriers of implementation or how it can be overcome. There was no explicit analysis of the dynamics between the interlinkage of climate change and inequality. There was no mention of debt relief. And I think what was absent in the debate was actually the discussion on public pharma, which we think would make a difference, considering that you cannot put out a complete picture of health and economy without public pharma. And then the last slide is actually just what we made as a statement during the WHA. Specifically, we mentioned that by just replacing metrics, we cannot create just economies. And I think I will end with that tonight. Thank you very much.
Thank you, Pao. And thanks to everyone. We're almost at the half past the hour mark. And as you can see, we've covered a lot of ground. I've indicated in the chat that this is just a small sample of what we covered during the watch, that the full list of agenda items and the documentation is available on the WHO tracker website, which is managed by David Legg and Dr. Sundar. And so if you want access to that, please click on the link in the chat. If anyone has a brief comment, a reflection they'd like to share, then we can maybe do that for the next 5 minutes. I'm really sorry about the lack of time. And I think you get a sense of how intense the work is of following the meeting, because for the watchers, they have to juggle many new topics and try and make sense of them. And I think the presentations today shows that they've done a really good job of demystifying some of the really confusing aspects of global health governance. So I don't see any hands. So perhaps what I'll do is thank everyone for coming. I'll check with the watchers if they're happy to share their presentations, and if they are, we can share them on the PHM website so that people can access them. I can also include a list of the links in the chat box on the website. And then perhaps also we can share some of the decisions and resolutions, highlight key ones, and perhaps distribute that by email if people would like to take up some activism in their region or their country circle based on those decisions and resolutions. So for now, I'll hand over to Annelien, who's going to close the meeting for us, and who is also the Global Health Governance Coordinator. So you'll hear a lot from Annelien when it comes to the program and its activities. Annelien?
So yeah, thank you, Lauren, and thank you to all the watchers for these incredible presentations. And I think also thank you very much to the interpreters. I know that it was a very technical thing to do the translation, and we spoke quick and we were passionate. So thank you very much for being with us and volunteering your time to make this webinar accessible in different continents across the world in different languages. So I just want to quickly also give us a bit of a going forward for the Global Health Governance Program of PHM, and a few things to maybe pencil down in your calendar. One of them is a webinar that we aim to organize on gender politics in global health governance, which would take place next month, also the last Wednesday at 11 UTC. And then the month after, we would start with kind of monthly meetings on global health governance, which are open forums for people who are interested in global health and the issues that we address today. A space for us to talk as health activists, to bring things to the table, really as an open agenda, to support each other in the work we do and the campaigns that we run. Lastly, I'm not going to take a lot of your time. I want to point out that in a few regions, there will be some IPHUs on global health governance. And IPHU is the International People's Health University. It's an online training course for health activists that want to know more about global health governance. But the program is really molded and defined to what are the important issues within the region. So it focuses on the WHO Watch and the regional WHO committees and watching these, and sometimes bring in other campaigns, etc. So I listed on the slide also the regions where that is taking place. If you're interested to join, if you're interested in shaping this agenda for the training, or if you want to participate, please go to the PHM website. And there you'll find the contact details of the regional coordinators for each of these regions. You can just drop them an email and they'll bring you in contact with the people, or you can contact us and then we can liaise or connect you with a relevant person in your region that is taking responsibility for organizing these IPHUs. So I think that's it from my side. I just really want to thank you all for your time. I know we went over time, but I hope it was worth it. And Lauren, I think that's it for today. Thank you again. Yeah.
Thanks, everyone.